the whole team of World Dental Association for their wonderful job for the past 7-8 weeks. You guys have been doing wonderful. So many webinars, so much knowledge has been shared on this platform. I think this kind of continued dental education has never been happened in the history of dentistry. World Dental Association. And I'm really thankful for your invitation. This is a great platform, and it's a great honor for me to be here on this platform today. Friends, in the beginning, let me be a little honest with you all. I'm a hardcore clinician and not into academics or lecturing or speaking from the stage to a larger audience, or this kind of audience has never been my cup of tea. And I have accepted this challenge. In fact, this is going to be my first ever live Facebook. And I hope by the end of my presentation, I do justice to this. So I'm going to share a little bit about my own personal journey in this field of digital dentistry and some of the workflows which I practice in my daily dentistry. I have been fortunate and lucky that digital dentistry has been my passion, and it has driven me to go around and seek knowledge from the world's best people, pioneers in this field, and who have given me a lot of knowledge, because of which I think I'm here in front of you today. And let me tell you a little bit more about myself. I'm a graduate of Nair Dental College, Mumbai, 2001. I followed Christian Kochman for his basic and advanced digital dentistry courses in India, outside India, Spain, Madrid, Brazil, along with Dr. Rajiv Masar. I also in a daily dentistry implant practice as well. Much of that is there, but my main passion is aesthetic dentistry. And whatever I am today known a little bit about because of my work is not only because of my hard work. Of course, there are a lot of people who have shaped up and given me mentorship at different point of time in my life. And this is a big platform for me to share myself over here. So I definitely want to thank a lot of people over here today. I would like to thank my professors, mentors from my own alma mater, at Nair Dental College. In 2001, when I graduated, I first thing wanted to go and start my own practice as early as possible, because that was a demand of my own life. In the first decade, it took me almost 10 years to survive in this big city of ocean, because I am not from Mumbai. And I had this dream of becoming one of the best smile maker specialist. But in the early days, I had to make hands meet, and my family survive in this city. And I always had a dream to meet Dr. Rajiv Verma. During my college days, I heard one of the first names in dentistry outside college professors was that of Dr. Rajiv Verma, and few more names. And I definitely want to thank him today that, sir, because of you, your passion, your enthusiasm towards dentistry is unmatchable. You have influenced n number of people, and I'm one of the beneficiaries because of you. I also would like to thank Christian for his DSD concept. Of course, the DSD company is the fastest growing company in the world today. I'm not going to talk about the company, but I'm a follower of the DSD concept as such, which we will talk about. I also want to thank a good friend of mine, Florin Coffer, for his my first early lessons in CAD/CAM dentistry, and my aesthetic work influences because of this man. Master of Masters, Master Paulo Cano. Thank you, sir. Thank you for his new skin concept, which I could early grab in my practice 3 years back, and magic makeup or 3D staining technique on the monolithic restorations. He has been mentored to so many dentists across the globe, and I'm one of the lucky guy to meet him in person. Another person which is close to my heart is this man, Dr. Jacobo Somoza from Spain. Lot of digital dentistry workflows and inputs from this person. So thank you, he and his team of George Cabanas, Laurent Stam, and our very own mentors in India also. During my early days, I was influenced by Dr. Ali Tunkiwala, Dr. Udatta Kher for their evidence-based ethical clinical dentistry practice preachings all across, and we are all lucky to have you over here. I'm an average clinician and have average practices in Mumbai city. 2 practices I have, these are my teams of doctors, and I don't have very high-end equipment or infrastructure in my practices, but despite of that, I'm doing I'm doing kind of dentistry which I enjoy the most today. A lot of doctors, a lot of my colleagues from all over message me or talk to me that how you are implementing this kind of dentistry in your practice. Your practice must be located in a demography which is probably high end, or your clients must be celebrities, or they must be from very financially affluent background. But that is a myth. It is nothing like that. It is my practices are very average based locality practices, and still my patients are very happy and they pay me for the kind of work which I do for them. And it is not that your patient should be a celebrity to do this kind of dentistry. That is a myth which I'll be breaking today with you all. This is my small family: my mom, my dad, my wife, my daughter, and my brothers, my sister and brother-in-law. This is a little older picture. My dad is no more now. We lost him a few years back. You can see a lot of hairs on my head. Now I lost a few more. But this is a small hut. I was born and brought up. This is almost 100 square feet hut on the outskirts of Maharashtra, on outskirts of a small village in Maharashtra. And I was brought up over here. I stayed in this hut for till my 10th standard. Yeah, I used to walk up and down 5 kilometers from this place for my school. My father shared a small amount of land with our cousins, and we used to grow vegetables like cauliflower, tomatoes, and sell in the local market to make the hands meet. That's how my life began. And when I look back, I'm really, really proud of my past. I'm thankful to my parents for providing me a beautiful childhood and the ability to dream big. And I'm thankful to God as well for providing me these adversities in life early that taught me to fight for my dreams. And I'm purposely sharing this on this bigger platform over here, that today when I see these times of COVID-19, a lot of my colleagues, a lot of youngsters are feeling dejected, depressed, worried about the financial status of their practices or future. But I would like to give a message, guys. Take this as an opportunity. There is always a change, and nothing remains permanent. Change is the only permanent thing in this world. So all these dark times will soon or later go away, and there is always light at the end of the tunnel. So don't worry about things. Just stay safe. Keep your family safe this year. And inshallah, from next year onwards, we all will fight back and claim victory over lives. We all will rise more mature, more wiser, more humble towards our fellow human beings and Mother Nature, Earth. So I'm very optimistic. Keep the faith, and I think it's just a matter of time. So it's not where you came from, but it is where you are going that should count. And that's what I have been always believing into. Coming back to our main topic of digital dentistry today, I'm going to share a little bit my own journey. It's not a teaching platform as such. How I evolved, or my practice evolved with this concept of digital dentistry and application of digital dentistry in my practice is. So you all will agree that if you fail to plan, you plan to fail. We all know this. If I have to describe a scenario 10 years before in my practice, and this could be true today also in most of the practices, that suppose if I'm reasonably knowledgeable in smile makeover procedures or clinical full mouth rehab cases, but I'm not a well-known dentist to a patients. So whenever a patient comes in my practice and I have attended some webinars, lectures, or continued dental education over the weekend, and I'm very, very excited that I'm going to change this person's life. I'm excited looking at the case. I imagine something that how this case will be finished and how the life of this person is going to change. But all this is in my brain. How do I communicate this vision of mine to my technician or to my orthodontist or to my periodontist? Even though we have read the same books, our perception will differ from person to person. What my orthodontist will imagine for that particular case would be totally different. And the end result over a period of time, whenever we finish the treatment, is most of the time not exactly what we had imagined. And that is what is main drawback of conventional workflows. And I think this is not my story, it is everybody's story. And this is where Christian Kochman also realized that something is going wrong even though he was working with the best people in the industry as their own in-house ceramist or technician. And they found that the conventional workflow of communications is from the chief dentist is not exactly happening the way we want. Forget about the patient. What exactly patient is desires are totally are not understood by the whole team, and patient is clueless all the time about his entire treatment proposal. And that is where I think patients are running away from dentistry, and they are not giving so much of importance to dentistry as we want them. Sometimes we know that we can change their lives for better, but patients have hard times accepting your ideal treatment plans, and that the reasons could be not because of only money. The reason is fear of unknown, fear of pain, and then the last could be the loss of money or time. But if we come up with something that gives a patient ideas right in the beginning, how they are going to look, what benefits they are going to get without we doing much talking, like if we are able to showcase them how they are going to look and all, that will matter a lot. So how this whole concept evolved? The philosophy of DSD is nothing but principles of smile design put together in the visual form, and that is what Christian did wonderfully. In those days earlier, we used to learn DSD on a PowerPoint or Keynote. These are the free softwares on your laptops or computers, and using the lines and curves and principles of smile design. Basically, this smile chassis is drawn in front of you, and the digital ruler gives you exact measurements in millimeters, and the whole team can align their vision on this small frame. And it looks very simple, very easy, but when we were learning this on PowerPoint in 2012, when I did my first course, let me be honest, I didn't know what is a PowerPoint is. I bought my first laptop for this course. I did not know what is a DSLR camera is. And we found, if those people who are listening and if they have done this first course of DSD, they will understand that it was almost taking almost 1 hour to do this kind of planning based on the facial principles and taking different pictures and cropping them together and coming to this form. And ultimately, if your patient says no, there's a big rejection. I think Rajiv sir can agree on this. And of course, nowadays we have various softwares like DSD software or DTS Pro software from my friend, which can give you this kind of smile 2D frame in few minutes. And there are some softwares which can provide you the simulations as well. But in around 8 years back, we used to do it on PowerPoint or Keynote. And let me explain a few steps how we used to do this. This is for the benefit of a lot of people who are not following DSD concept or who have not understood what these lines and curves mean for. But we used to take these two pictures, front pictures, one with cheek retracted, one without cheek retracted, one 12 o'clock picture from the back side. Nowadays, we take it from the front side, occlusal picture, and these pictures we put together on a PowerPoint. These are the lines and curves, golden proportion. It is all there in your PowerPoints. This is a free software everyone has with them. So anyone who is keen to learn without spending any money about your DSD planning can go on YouTube, watch some tutorials over there, and open up their keynotes and find these lines or draw these lines and curves. And basically, you take pictures, rotate the picture in a way where you make the interpupillary line parallel to the incisor line, and crop the pictures. Basically, there are different steps where you will define the central incisor positions, midline, coinciding with facial midline. The incisal edge position is determined by taking a video of phonetics, and basically it's a pure judgment based on your visibility parameters of male or female case, how much incisal length of one of the central incisors should be seen. And it's a pure judgment. Based on that, you draw your incisal a smile line which is parallel to the lower lip line. And the golden proportion is always already set in depending on the availability of the width of the case. And then you want to go and find the gingival curve or see the zeniths of the patient. So that's where you need a cheek retracted view. So basically, you need to have these two pictures in the same spatial positions of X, Y, and Z axis of the face. So you will draw these three lines from the canines to canine, so incisal edges of the centrals, and one vertical line passing through the midline of the or passing through the dental line, and delete that picture, keeping those three reference points, and take your cheek retracted view, crop it together, and enlarge it, and just try and find gingival genius. Now we are having the same picture, which is parallel to the interpupillary line, and basically you duplicate the incisal smile line, and make it as a gingival curve. And this is a pure judgment from here on whether this smile line looks good or this smile chassis looks good. You will play around with gingival line, make it either little curved upwards or straight at the most, and this is what is exactly your smile chassis is. Once you are able to get into this, you will put one pre-calculated 80% box, because that is where the ideal width, height, and width ratio of the centers we consider. So the variations could be 75 to 85%, but we'll start with the 80%. We are sure that I'm going to increase probably a 2 millimeter length in this central incisor based on the phonetics, and my box exactly shows me that I don't need any kind of gingival correction for that central. If it is a gummy smile case, I might want to go ahead and increase the proportion or decrease the proportion below 80%. So it is all clinical understanding and playing around with these lines. You can select outline from these templates of libraries. Now there is something called as morphopsychology or visagism concept. I don't believe in this concept so much nowadays. But you can go into the details of personality of the patient, and depending on personalities, there are various outlines or the shapes of the tooth which are suggested, and you can pick up any of these outlines, go into that box, and just enlarge these outlines, and put every tooth, duplicate every outlines for one side, probably from the right side to the left side or whichever way. And one beautiful thing over here is the digital ruler. Now, the digital ruler measurements are exactly calculated based on the individual measurements of your case, depending, like you can measure the exact width between the two centers in the patient's mouth or on the study cast, and transfer that width on this digital ruler. And now this ruler is customized for this particular case, which you can take the ruler and do your measurements from whichever place you want. Like incisally, I want to increase around 1.6 or 1.7 exactly in millimeters. And with this frame, now everybody of your team, your technician, is on the same wavelength. Without this frame and with this frame, it makes so much of a difference. And conventional dentistry has been happening for so many years. Like we take study models, we send this study models with shabbily written notes to our technicians that you want a wax up, and do a nice wax up. And when we show this wax up to the patient or do the taste drives, so many things are going wrong, and we don't know why they are going wrong, because our technicians don't even know the patient is a male or female. We do not have shared the pictures with our technician. And even if we share the pictures and not this sketch or this drawings as per exact facial planning, then also things are clueless to them. So I believe this concept of DSD 2D planning has changed many things and given us many benefits. From my point of view, I conclude the advantages or benefits, like it gives a clinician a definitive roadmap of final outcome of treatment before initiating any permanent changes in patient's mouth. Involvement of interdisciplinary team members is considered before taste type. So if your orthodontist or periodontist are going to be involved in this case, they know as per the measurements to how much of work requirement is expected from them. The treatment time, cost, and choice of materials can be evaluated before initiating treatment. So in the first appointment, we collect the data, we do the planning, and in the second appointment, when we present the taste drive to the patient or showcase to the patient, we already have broken down our cost and our duration of the treatment and involvement of our team members. So we are very, very clear about our treatment proposal to the patient. When patient is involved and in the entire process and the plan is broken down in steps to him, the cost of the treatment is completely justified to them. And if there are any minor changes required from their point of view, we always can accommodate that or carry out another test drive before going further. Now, DSD planning, along with complete digital workflow and screen concept, has completely revolutionized digital dentistry, in my opinion, at least in my practice. We'll talk about this. So in a nutshell, what DSD is doing is it is strengthening our diagnostic vision. It is improving our communication with our team members, and it is enhancing predictability, because as long as the case is going on and these lines and curves of customized patient are in front of you on your screen, maybe the case will take 1 year or 2 years to finish, but you know your destination, where you began and where you want to go. Now here I'm showing the DSD planning only in the buccal view, but of course you can do this planning for a 12 o'clock view and occlusal view as well. But nowadays I do most of the jobs in complete CAD CAM, so this much frame is enough to begin with for us. A lot of friends tell me that my patient has rejected orthodontic treatment. DSD mein kuch hoga kya? So they consider DSD as a treatment in itself, and it is not a treatment in itself, but it is just a treatment planning tool. The concept was wrongly named only as a TSD, and people used to think that if you have given a test drive to the patient should be finished with giving veneers or some kind of restorations, and if patient doesn't agree with that, it is a failure of the treatment. It is a failure of the DSD. It's not like that. It's a treatment planning tool. And if the case requires some kind of ortho and you cannot find a middle path, then probably in such cases I will leave the case and not chop off the teeth just for financial benefits. So this wireframe, I call it as which is a central point of integration in the CAD CAM as well. Definitive restorative space 3R concept. In dentistry, we are doing this 3R concept. What is it? Basically, either we are restoring teeth, either we are relocating teeth, or reconstructing teeth. So restoration is like an endo or prosthodontic treatment, relocation is ortho or perio, and reconstruction is tissue biology and implantology. So basically, if we have the DSD frame with us and the digital measurements with us in all three directions, then we would definitely know how much of ortho or perio or prosthetic work in millimeters is required to get to the ideal aesthetics. Now, when we are talking about aesthetics, it is important and paramount importance that we showcase the plan to the patient in the way they should understand it. Let's have a look. Well, that was not a treatment results final. That was just a taste drive planning in a 3D in the patient's mouth, and the showcasing in a different way. There is a famous quote by Zig Ziglar: people don't buy for logical reasons, they buy for emotional reasons. And this is one important thing as a dentist we need to understand. Because of our love for dentistry and technical dentistry, whenever we are consulting patients, we are talking from technical point of view. And people don't understand the techniques or technicality behind the dentistry. And that is where most of the rejections do happen. If you take any kind of advertisement, that could be your life insurance, medical insurance, cars, mobiles, they don't talk about the technical aspects of the product or service. All they talk is to trigger your emotions, because most of your decisions of your life are based on your emotions and not because of your logical. There is this study, all of us have left brain and right brain. Left brain is indicative of numerical, logical, rational, objective, and analytical questions. Right brain is totally artistic, creative, subjective, intuitive, and emotional. And as I mentioned, all our decisions are based on our right side of the brain. You need to tickle the right side of the brain, and the emotions will come out, and then people will make the decisions. Most of the time in our patients' lives, dentistry is not up in their priority list. Dentistry is last. It is only by, it is never by choice. It is when they are forced to see a dentist, they come to the dentist. And if we are talking only about the technical aspects of dentistry, thinking that patient is going to accept our ideal treatment proposal, for which of course he will have to spend the money, they don't accept it because we are not into their priority list. So we need to put up our treatments or our treatment proposals in their priority list. How do we do that? And हिंदी में कहावत है, जो दिखता है वो बिकता है. So unless we showcase them what dentistry can do to their lives before we initiate the treatment, most of the time our treatment plans will never be accepted by these patients unless you are very, very famous dentist. This is again a taste dive done at my friend's clinic, Dr. Manish Fitness in England. I was there when I was doing this taste dive with him, and this is a before and after. The patient is delighted. We had a wonderful reaction of this patient. This is the same patient before her orthodontic alignment and after the taste drive, not a final treatment, friends. Okay. This is her reaction. If Manish is there and he's listening, he will recollect it last year. Even my friend got emotional. I was emotional because of her happiness.
I didn't expect that actually at all. I really love it. I'm sorry, I'm crying. God, they look really nice. All my life I had that kind of thing where I was really ashamed of, but now they look really nice.
And imagine with the new hair, lipstick.
So this patient had almost lost the hope of looking good, and she was so much low on her confidence. Her entire family, the husband and son, they came along, and everybody cried looking at just the taste test. And these people were not so affording, but they made the decision then and there itself. Come what may, whatever it takes, they are going to accept the treatment proposal, and all other priorities will be shifted, and dentistry would be put in the priority list for this case. So if we are successful into planning and showcasing before the treatment is initiated, that is a win-win situation for us. And we all will agree that in dentistry, we all have a scope of doing this kind of test drive at least for 80% of the cases. All of 80% of the cases are additive cases. There would be some cases which will be part additive and part subtractive. That in those cases also we can do test drive using some tips and tricks. And there would be very few cases which are totally subtractive cases. And in these cases, the simulation and your different kind of 3D planning can help to communicate with the patient. But 80% of the cases, definitely we can give a test drive, and that is a game changer in my opinion. So let's have a look at one of the case where I have done DSD 2D planning conventionally and analog workflow, where I have asked my technician to provide me a handmade wax up for my test drives and do a lithium disilicate veneers with cutback technique. So let's have a look at this case. She is 22-year-old female, comes to me with these two bulky crowns in the mouth, and she has impending marriage in 2 months' time, and she wants to get these two teeth look natural. That is her main desire. Is they are bulky, make them smaller, and make them look natural. Of course, I can see some restorative dentistry required over here. As per my protocol, I take her all the pictures in different views, do my planning. A patient is already consented for removal of these two crowns. So we took off these two crowns, take the impressions, send this planning to my lab, and get a nice wax up done based on these measurements. My technician does a wonderful job, gives me precise wax up. I make a silicone index, and then the second visit when patient comes, I put a pro temp in the silicone index and put this in the patient's mouth. Now this was reasonably well. Patient could understand the difference it is going to have in overall things, in overall area of her smile. And yeah, she did accept 8 veneers job. Or she could have an option of going only for 2 lithium disilicate or zirconia crowns of her choice. only for those two. But she could see that the taste dive is giving her a homogeneous smile, and that is going to enhance and improve her confidence in life. So she accepted. I go ahead and do the preparation through the mock-up, like a Golly-Burrell's technique, aesthetic pre-evaluation technique, to remain minimally invasive, to remain in the enamel. That is the whole goal when you are doing veneers. And when my technician sends me the BIS trial, I go back to my smile frame and put the same picture back over there. And now I don't need to pick up a phone and tell my technician where he needs to add or remove his ceramic. He does a beautiful job. I get the finished product, and I bond these restorations in the patient's mouth. This is how her smile looks like. Of course, I could have done a little bit of gingival depigmentation, but she was not keen on this. She had a marriage in coming weeks. So we left it at there, and this is how we finished the case. This is not a very complex case. This is a very easy case, and anyways, only with the 8 restorations have changed her life forever. And I did this kind of work for many patients, and then there was monotony which sets in. Monotony by means which I am saying here is I found that every time patient comes, I take up the impressions, I do the wax up, I do the DSD planning, I do the wax up trials in the patient's mouth. Patient's happy. We prep the teeth, or we do ortho, perio first, whatever things are required, and then in the end, if they desire veneers, we go ahead with the veneers in the analog world. Now, what I found over here is, if I took close-up pictures of all my previous cases, and if I had the same technician working for me, every time all those smiles used to look the same. Then I noticed that if the same technician is shared by my colleague, and we take up his close-up pictures of his cases, the smile still looks the same. So there is a signature of the technician working behind. You don't know who is the clinician, but you know who the technician who is working behind those smiles. And that made me realize that something is going wrong, not wrong as such, but it is a routine. Now there is no excitement into it. And fortunately, I was not the only one who was thinking this. This person, Master Paulo Cono, was way ahead than my thinking. And he's basically a ceramist and implantologist. Many patents, many innovations on his name. But coming to his concept of new skin, what he saw is nature is always ahead of man. Man can never match to the nature's abilities. We all can try and mimic with our hand skills. And he found out that every person in this world, we can have hand-eye coordination, which can be give us only 2 or 3 variations the way we can sculpt or carve the teeth. And nature, every tooth is beautiful. It's the surface texture, morphologies, minor irregularities are unique to that tooth, and they are based on the DNA of that person. Or the shapes and morphology is the part of the DNA, and that has never been duplicated by nature itself. So nature is full of this kind of designs, and then if there is a way we can copy all these teeth in their original form and duplicate and make them for us, then we no longer need to design or sculpt the teeth with our own hands. And with this thought, he came up with this concept. He got hold of Jan Haito's these beautiful models of the patient's teeth, and he made silicone indices out of this, cut the silicone indices in 2 parts, buccal and lingual, and then used the buccal side, put a thin layer of composite on them, cured it, and made these shells of composite. You can see in the lower picture. If you can look closely, the shape and surface texture and morphology is exactly the same as in the top model. So basically, the natural replicas are made from these composite shells, and these composite shells were used to give initial mock-up or trial or a test drives to the patient using a little bit composite inside. And once the patient is happy with the final outcome, what Master did was he scanned this taste drive with intraoral scanner, and now the scanner software has the final outcome file in the software, and then he go ahead and prep the teeth for veneers and scan them again. Now the software has the two files. One is final outcome file and one is preparation file. And in the software, you do some certain calculations, and whatever the space left is a space for the restoration. And now they mill these restorations in glass ceramics, lucite glass ceramic, Empress materials were used. And to their surprise, the milling machine is like a Xerox machine. It will give output what is in the design. So they got the shape and little bit of morphology, not exactly 100% morphology in this workflow, because it was indirect workflow where the shells were made from the models and the shells were then scanned. So there was loss of surface textural information in the final workflow. And this is the beginning of change in the dentistry. This is he called as a new skin concept, because skin is the outer membrane of your structure or anything else. And nowadays this concept is completely revolutionized. It has completely digitalized. You no longer need these composite shells to stock in your practices. Everything is in the softwares. All those digital libraries are in ExoCAD or 3Shape, or you can make your own libraries using multiple softwares from live patients and use these shapes to create your 3D printed mock-up trials. We'll see some cases based on that. CAD/CAM dentistry is nothing new. It has been there since Sirona's started this concept in 80s. Almost 35, 40 years has been there. But all this scanning, CAD designing, and milling, CAM machining technology has been used most of the time only to create prosthetic substructures, not the final restorative dentistry. Most of the time our technicians used to work with their hands on these restorations, and that gave us the limitation of using the potential of CAD/CAM dentistry. But with these two concepts, digital smile design planning 2D and natural restorations, and of course now there are multiple digital workflows which have been integrated to give us accurate planning which comes into reality because of printing and milling. We'll see some cases. Now, from my understanding, the full 3D digital workflow is divided into 3 zones or 3 categories or 3 departments, I would say. One is capture of the patient or digitization. Second is the processing or the patient digitization. These are the softwares or CAD softwares. Third is manufacturing or the patient digitization. Again, we'll see it as a CAM or the final outputs. So we'll see what are these 3 segments. Let's talk about the first part of it. Patient capture or patient digitization. Now there are 5 things over here, and this is of most importance to the clinicians or the dentist part of it. Whenever patient comes to your practice, we try and capture all this information from the patient. So conventionally, we are taking impressions, we are taking X-rays, IOPs, we may take CBCTs, or if we have, or we refer to them. So what is the ideal way of taking digital records of the patients? What are the armamentarium required for us? First is taking photography or videography. Second is surface scanners. Third is volumetric scanners. Fourth is photogrammetry. And fifth is the fourth dimension of this. Until now it was 3D. Now the fourth dimension is capturing the jaw movements as well. So let's see. Photography, videography, it's nothing new. I think wherever your practice is in the entire globe, we all have access to either of these 3 things. And mobile camera, smart mobile phone is, I think, is now paramount. Everybody has it. So the first step of becoming a digital dentist is being able to take good pictures of your patients, the face pictures. And you don't need many pictures, just need 4 or 5 pictures to take from your camera. And the use of lights is important. One need to understand how to play around with this technology, how to use the light. And it is not a rocket science. There are good mentors around. If you are keen, please find out and attend 1 day or 2 day workshops from them. And at least you should be able to take the required pictures for planning. And these are the 5 pictures which I suggest to required for the planning. The patient's mouth should be a little bit open and molar to molar smile. Both the ears should be visible equally. One with cheek retracted, one without cheek retracted. Another is 45-degree molar to molar. At least the second premolar tip should be seen, mouth little bit open. 45-degree smiling picture. And another picture is 12 o'clock picture, just to see the proclination or reticulation of the upper anterior teeth. These three pictures and a small 30-second video to judge the phonetics and visibility of the teeth is more than enough for your initial planning of DSD today. Now, whether you want to do it yourself using free softwares, or if you want to purchase any kind of software which is easily available in the market, it is up to you guys. But these pictures and the 2D planning is most important to begin with. And even if you're not able to do your DSD planning yourself, there are people around, there are labs around which can help you. You need to find out. Next thing is tabletop or surface scanners is about laboratory scanners. I'm sure most of the people know about it if you have visited to your dental labs. And most of the dental labs, almost all of the dental labs will have one unit like this, where they pour your impressions in the stones and convert, scan these stone models and convert it into a digital file. And they're pretty good. Intraoral scanners is again one of the next revolutionized digital dentistry today. There are multiple brands, and every now and then new brands will be coming in the market. I personally own a 3-shape scanner in my practice. I'm not a spokesperson for any kind of scanner, any kind of company, but I'm happy with what I have today. And the R&D team is doing wonderful job on their various softwares. So any scanner which is able to give you an STL output, almost every scanner gives you the STL output today, is able to do your job. It's just that the speed of and the size of the scanner does also matter at the time. So the final outcome file, there are various file outputs these scanners can give you. The most common file is STL file, which is a colorless file, which is read by most of the softwares, CAD softwares for the processing of these files. DCM file is a specialized DCM colored file from 3Shape, where you can record the shade of the tooth as well. Not 100% correct, but around 90 to 93% correction in the shade reading can be done with this kind of scanners as well. Another surface scanner is the face scanners. Now the face scanner there is again under development, but most commonly and widely used today is a Belus 3D app. This is there in your iPhone cameras, iPhone 10 and above versions, and you can subscribe to you can download the dental Belus 3D app, and you can subscribe to their software and use your mobile phone to do the face scanning as well. Of course, there are CBCTs coming up with this kind of technology, but again, it is not a mandatory as of now. The next thing is volumetric scanners. We all know that CT scan or CBCT scans we take up to study the soft tissues and hard tissues. This is the unit is called as voxel unit. It is a cubic form, so there is a depth into this kind of files. The surface scanners will not have a depth. It is only a one-sided mesh, triangular dots connected together, and inside it is open. Here it is depth-wise is there, so you have a volume inside, and this file is called as DICOM file. Now, some people do study model scanning with CBCT scanners and try and make their implant guides on this. But the accuracy of these scanners is around 150 to 200 microns for study models, and intraoral scanners is in the range of 5 to 7 microns. So there is a discrepancy, and the guides which are made by scanning CBCT with study models are not very, very accurate. Another thing is photogrammetry. If your practice is mostly implants, and you know that the prosthesis which you make has to be a passive fit in the full mouth rehab cases most of the time, and if it is not, then you are doomed for the prognosis of the case is concerned. And this has been a big challenge, taking a good impression, passive impression, sending it to the lab and getting the same in back. It takes a lot of time, and at times you may have to repeat things. To overcome this, we can try and use intraoral scanners, but scanning with intraoral scanners up to 3 implants or 4 implants which are closely placed is good enough. But for entire arch scanning with the scan bodies and scanners hasn't been so successful yet, even though some people have claimed they are getting success with smaller scan bodies and scanning with the full arch with the interval scanners, but I'm yet to find that success in my practice. So another thing which is recommended is a photogrammetry. This is a extraoral device with the two cameras, and the dots are basically scan bodies, and the camera and the software will read these dots and from intraoral mouth, and within a few seconds, based on the photogrammetry principles, they can exactly locate where the implants are placed, and you get an STL output of this location of implants, and you can merge this with your other files of case, and then the technician in the CAD software can plan the processes, so you no longer need to take impressions. There is a PIC camera, which is a Spanish company which provides this equipment, and I think one more company, but I don't think that is working. I think IMET or something. Now jaw movements is the fourth dimension. This is again one great help. By far, we have been able to capture the static positions of the patients. One is jaw scans, either with a surface scanner or lab scanner, internal scanner or the lab scanner. Then we are able to scan the soft tissues and hard tissues. Then we are scanning the face. And now we need movements as well. So there's this device called as jaw. Basically, the device, you attach one device on the lower jaw and ask the patient to do all sorts of movements, and the external camera will record that movement, and it will generate a file of all these movements, which you can incorporate in ExoCAD software. And now you don't need to program your virtual articulator. You can directly use these movements in a real movement of the patient in the virtual articulator. To make your restorations. Now, in the 3-shape, there is a trio specific motion. Using this interval scanner, you can scan one side. You can scan one side movement like this. Yep. So nowadays we are able to capture a patient in toto in digital format, and once the patient goes, all these digital files which are captured in various softwares need to be put together to make the patient's digital clone like this. On this picture, if you can see, I have aligned the patient's CBCT, interval scan, face picture, and if I would have a face scanner also, I can align that face scanner on this and make a digital clone of the patient. Now, using this information, we can very well diagnose, plan the case, and create various templates required maybe for taste drives, crown lengthening procedure, injected composite templates or guides, implant guides, implant processes. Everything is possible. And the best part is that you can send this information within seconds to any person in the world through mail or any kind of communication mode. And this person or your team members may not need to be present in your practice. This is the biggest advantage of digital dentistry. And all your plannings, all your templates are made, and this is where the concept of copy paste dentistry originates. And the best thing here is, even if you are average clinical skills but sound clinical knowledge dentist, you can provide the best treatment to your patients based on these templates and planning into the 3D world. So the second part is about the CAD, or the most of the softwares like Serec, 3Shape, ExoCAD. Nemotech. These are the major softwares which will process all this information which is you have captured in the clinics. And now this is a big area which is developing, and there are a lot of specialists required to work on these kind of files, this kind of softwares, because every software company has different multiple modules of restorative dentistry, implant dentistry, orthodontic dentistry, and there is always an update coming up. There is a lot of innovations happening, so one really needs to be trained in handling these softwares, which takes a lot of time, and there is a learning curve on this. So for small practices, it practically becomes impossible to invest into so many things. And the only thing is that you need to be aware the whole ball game behind this whole dentistry, and you should be able to delegate this work to the labs or to the people who are mastered into this kind of processing your files. And as a clinician, the focus should be how to implement these workflows in your practice, and that is where I think the concept of group practice or group dentistry is going to come up in a big way in coming time. The third part is manufacturing or patient digitization. That is the CAM output. As we know, the milling or the grinding and the 3D printing. These two things, whatever is in the design, these two things are like your Xerox machines. They will give the final output exactly what is in the design. So your designs have to be really accurate. Milling machines are various types. It could be 4-axis, 5-axis, wet machine milling, dry milling. I'm not going to go into the detail of it because this is for the technical side of people who are handling the back office of the dental work. Various dental materials are available like glass ceramics, PMMA, metal, PEEK, anything whichever you think of is available for you either for milling or printing. 3D printing is again taken the dentistry by storm, and I think eventually with time milling will be out and 3D printing will be in. Most of the work like implant guides, study models, face drive models, crown lengthening guides, temporaries, dentures can be printed in your own office, in-house, and these 3D printers are not very expensive. If some of you are looking to take the plunge of becoming a digital dentistry clinic, I would suggest, even if you don't invest heavily into the equipments, but only two things which are important. One is your photography equipment, and I think everyone has the good mobiles with them, so they don't need to invest money to capture the digital information for the patient. Even if you take good impressions and send to the labs can convert your impressions into a digital file. CTCT machines, if you're not investing, you can always refer to the center which gives you DICOM files. Photogrammetry and other things are not so important as of now. So you can send all this data to your planning center, whoever is helping you out with workflow. And if you have a small 3D printer in your office, which is like a desktop coffee machine, and which doesn't cost much, maybe a 50,000, 60,000 bucks, and that's it. And your practice is set to become a digital dentistry practice. So you don't lose time also. Everything is printed in-house for you. And your patients are also delighted to receive 3D dentistry in their in your small practices as well. So this is a little small digital wax mockup is being designed. So this is the overlap of 3D over 2D. So let's have a look at one full mouth rehab case where I have incorporated all these learnings into one case, and this was one of the first cases where I have incorporated DSD planning with a 3D workflow, which I learned from various people around the globe, and uh, tried and implemented a full mouth rehab case. So this case is a 25-year-old man comes to me with generalized enamel hypoplasia. He got mild sensitivity to most of the teeth. A major complaint was unpleasant smile and lack of confidence. He was socially embarrassed because many people used to ask him, "Are you a good chewer or tobacco chewer or something like that?" And he did not feel good about it. So he did consult many dentists across, and then the treatment plan which was suggested for him was root canals for most of the teeth and full mouth rehab with either PFM crowns or zirconia crowns. But he was not convinced. He read about his conditions overall and somehow landed with us after initial consultation and initial data collection, like these pictures which I'm showing over here. These are the various pictures which are taken to showcase to the patient after the treatment is done or during the test drives. Interval pictures, you can see the collapse bite, mottled enamel all over, upper jaw. You can see almost dentine is seen on most of the teeth, lower jaw, and the close-up of interval pictures. This is a 25-year-old young man. Fortunately, there is no pulpal involvement in any of the teeth, so no root canals were required or suggested for this case. This is my after my consultation is done, intervals pictures are taken, interval scanning is done, and this is the first 40 minutes of the patient. Next visit, when patient comes, I have done my homework, I have done my background work, I do my DSD planning to here I have used a Keynote software to do this planning, and this planning I take to this is the planning in the three different views: 12 o'clock view as well and palatal view. From the palatal view, I can easily say that the teeth are little retroclined, but I can definitely correct the retroclination with the prosthetics, and I don't need to suggest him ortho in this case. So I take this planning to my 3D software, 3Shape software, and use the natural shapes to morph based on the DSD 2D planning. And basically, this is the file, different translucencies, is just to make you aware that how the 2D planning is incorporated into 3D, and it gives a volume. The side profile shows the exact textures and shape maintained throughout. Now, to maintain this exact natural shape and surface textures and morphology right in the planning to the printed models to the final restorations, it definitely requires a specialized training. Not all CAD software guys would be able to preserve this throughout their treatment. So a lot of people are still today doing digital dentistry, but not able to get the final outcome like what exists in the original file format from the libraries. So it definitely needs training for that matter. This is a 3D printed model, silicon index for the same case. And when the patient comes in the second visit, now our magic starts for him, because till now he is only accepted our test drive cost and not beyond that. And we have not proposed any kind of treatment, neither we have given him the final cost for this treatment. So when he comes next, within 15-20 minutes, I take the silicon index, put a pro temp, A1 shade preferably, and take these photos and videos and showcase on a bigger screen like I explained earlier. And that's how he looks, and is a visibly delighted patient, is very, very happy to know further what is the plan. This is how he looks, this is how his test drive is. Of course, a little bit of retroclination is still seen on one of the pictures, but this is corrected in the final designs as well. And the plan is given to the patient that he needs a full mouth rehab with raised bite. Fortunately, there is no TMJ involved, so I don't need to involve any TMJ specialist for this case. A little bit of crown lengthening or gingival shaping is required as per the mention in those teeth. And we suggested him full empress restorations, full covers, because dentin is motile enamel is present all over. So up to after 28 restorations with monolithic restorations and based on the natural restoration concept. Up till premolars, the material I have chosen is Empress CAD Multi, that is a lucide glass ceramic. And for molars, for obvious reasons for the strength, I selected lithium disilicate or Emacs. So what I did, once the patient is signed on the dotted lines for the treatment, I go ahead and prep the upper 14 teeth to receive the restorations. I scan them. I take all the scans and informations to my CAD software. I merge both the files of preparation file and on the test drive, approved test drive file, and you get the individual restoration files designed. You put this in the CAM software, and it goes for milling. And here are the 14 milled restorations. The white ones are up till second premolar. This is Empress, as I mentioned, Empress CAD Multi, and the molars are Emacs. Now all these are monolithic restorations. What I do next is only just cut their umbilical cords. I cut their connectors and just do the finish and dry polish. No burr is applied on the surfaces because this was in the design, and milling machine has exactly replicated my designs. The fit is fine. I tested on a 3D printed dies. Then I go ahead and do the 3D scanning technique as suggested or taught by Master Paulo Cano. What he does over here is, this is only for glass ceramics, and he uses the true colors, not the shade stains. Like the shade stains are A1, A2, A3. They have the black element into it. So when you put these stains on this glass ceramics, the value goes down. And what Master does is he uses red, yellow, and blue. And all these other colors are basically permutation combination of these three basic colors. Using these three colors, like you put a little bit of red, oranges on the cervical, middle in the oranges, and inside the lid you put a little bluish. And basically you choose a CAD block of the shade which you want, maybe A1, A2, B1, whatever it is, and just enhance the basic shade with these stains. What I found over here is you can substantially increase the value with these true colors. And a lot of patients do come and tell us that I want white teeth. And we think that we should give him bleach shade. But what I found in my cases is even if you use A1 or A2 shade and increase the value, that also appears whiter to the patient, and patients are really, really happy about it. Putting totally bleach shades, patients could be momentarily happy, but over a period of time, we know that they look really fake. And in this case also, I have done A1, but you will see how white it looks. And patient is really delighted with because of not just the white shade, but the shape, which is a replica of nature. These are the final finished restorations. I have taken these pictures with particular camera setting just to highlight that how the staining is done. In the mouth, of course, it will not look so bluish. The fit check on the printed models. The printed models were from photon printer, which is not very, very good to check this kind of fitting on the models, but it is good for test drive printed models. Now, this is what is real copy paste dentistry. If you look at this image, there is one on the right side is the STL file picture, and the final outcome is next to it. I have purposely taken this picture on this finger. You can see the surface or the skin of that person. There is a particular pattern into that, and that pattern, if you check the metascan, it is unique to that person. It is in the DNA of that person, and that is what exactly Master Paulo says, that every tooth shape and surface is unique to that person. It is never duplicated. But today we have this technology where we can duplicate it and use it for the same human being in future, or you can use it for somebody else. And that is where the concept of smile donor also originates. And we no longer need to design or sculpt or scout teeth anatomies by hand. All these upper restorations are fitted in the mouth, and this is how it looks, almost perfectly natural. Yeah. This case is very close to my heart. That's why I'm showing so many close pictures as well. And this was one of my first cases, which I'm really proud of it. This is in the design, and the same design is in the mouth with the monolithic restorations. No cutback, no layering, and this is how it is. Look at the closest picture. Look at the 3D staining giving so much of naturalness, because it is not only with the stains, but the shape and morphology is exact copy of what exists in the library, or the reality basically. uh, Before and after. Now, most of the patients are surprised at the time of test drive itself. They don't get surprised at the final work, because the final work is just a replica of the test drive. It is in the finals, you can see it is almost the same. Only thing is that every tooth is separate in the finals, so that it feels more natural to the patient. And the test drive is also looking more natural. So that is where my patients get convinced what exactly to expect in the end. So there are no surprises. Everything is from the test drive, duplicated till the finals. Now it is dentist's duty that whatever is shown in the aesthetics, you have to maintain your function, your biology, and then deliver the aesthetics. At times there would be complications in the case, and you can make the patient aware beforehand that whatever I am showing in the aesthetics or a test drive may not be achieved in the end because of certain difficulties, which could be a malpositioned teeth, and if they have not selected the ortho option, and there has to be some kind of preparation required, uh, you know. So your patients and you are all aware about the final outcome right at the beginning. Once I am done with the upper, I go ahead for the lower. Now, I could have done upper lower together, taste drive functional as well, but I was not very sure that I will be able to successfully complete this case with this kind of workflow, because whatever I had learned outside from various people and I had to come over here, I did not have enough infrastructure. I did not have enough money on hand to develop a team immediately, and whatever I learned, I had to test first before I could teach somebody. I was not very sure that I will complete this case. Now, after upper is done, I was fortunate that this was a simple case to go ahead. I designed a 3D coils deprogrammer with proposed increase in VD almost anteriorly 3.5 millimeters or 4 millimeters. I don't remember exactly. And I test this 3D deprogrammer in the patient's mouth for 8 to 10 days. Patient is comfortable, no load test positive. Patient is quite comfortable with this much raise, and I go ahead, I do the interval scanning of upper jaw, finally finished, lower jaw, and the bite is intraorally scanned at this point of time. So this is exact VD which is required for me, and a completely deprogrammed relaxed mandible in its position. And then I take up this file to my, again, 3Chef software. I put arbitrary values for articulators and design an anatomical wax up. And again, I go back like in the upper jaw. I repeat the same thing in the lower jaw, and this is now functional and aesthetic test drive for this patient. Of course, I know that I still need to play around the areas of canine. I need to increase the occlusion, make a proper occlusion over there. But this is a test drive, so of course you can correct it in the due stages, and you check the occlusion. Hardly a little bit of adjustment is required. Test this occlusion with the protem in the patient's mouth for a week or so, and I go ahead, I prepare the lower 10 teeth, keeping the molars. But before that, what I do is, once the patient has been comfortable with this raised verticals, I scan the upper jaw, I scan the lower jaw with the protem on, I scan the bite, and this one file is my reference file for my future preparations, because I have the bite in my software, which is where the patient is comfortable. So I go ahead, prepare the lower 10 teeth and scan them again, and use this scan to align with my bite in the software, which already have taken before preparing the tape. I go ahead using the same natural restoration concept, prepare, design my files, send them to the lab for milling, and they come like this. I finish, polish, do the staining, 3D staining, and this is in the mouth. Now, this is before and this is after. Preparations on the model and in the mouth. I'm not very happy with the lower fits. I did not have enough time as patient was leaving in 2 weeks. Otherwise, I would have repeated the lower restorations. Since I told you I was new and the CAD machines had some problems, my designs were not exactly replicated at the margin level. Few of the margins I could see they're a little open, and I would definitely have treated him again. Whenever he comes back, I'll definitely do that. This is how he looks in the final, and this is how his occlusion is done. Maximum intercuspations, anterior and canine guidances. And mind well, friends, I have not used a face bow or articulator for this case at all. Everything is tested in the patient's mouth, which is the best articulator, and then the same thing is replicated in the monolithic restorations. After the restorations are bonded, I scan the upper lower jaws bonded restorations, and the 3Shape software after the scanning gives you this kind of diagram of showing the intensity of occlusal contacts between upper and lower jaws, and that can help you to adjust occlusion. Not an option for T-scan or something, but it definitely can help you. And this is the final outcome of the case. Before, and this is how he leaves. And this is an A1 shade, not a bleach shade or something. This is an A1 CAD multi of Empress and a delighted patient in the end. Some close-ups. Yeah. No cutback, no layer, no face bow, no articulator. When I'm sharing these credits, everything, almost every step is done by me personally as a DSD planning clinician, digital technician, ceramics, documentation, photography. Because as I mentioned, I did not have enough team to handle this kind of work. Nowadays, I'm developing my team for each department, and we'll be trying and helping many other dentists to incorporate these kind of workflows in their practice. I'll talk about this in the end. I will show quickly one more case based on similar concept, but here also I have incorporated another concept like injected composite. We'll talk about that. So this case also comes to me a few years ago in my practice. I was not 100% into full digital dentistry workflow, and this case come up with the chief complaint of spacing in the lower teeth. The smile is not very confident. Posterior upper molar, upper both sides have a PFM bridges, which patient is not happy about. The central and rattle, somebody has done root canal and miracle mix, and she's afraid that it will break anytime. Lower molars are missing. So basically, after collecting my pictures, impressions, I sent the impressions and this planning to my technician and get a wax up done. Full mouth wax up is done, and this is in the mouth. She looks not so good to me. I was not very happy with this taste time because everything was looking chalky. Even though the wax up was really looking nice outside the patient's mouth, but when I transferred the mock-up in the patient's mouth, this was looking too bulky and chalky. But to my surprise, this patient did accept my full mouth rehab treatment plan, and I was fortunate on this case. She accepted the treatment, saying that she will come back in 2 weeks' time and start it, but she was on vacation and she broke this tooth before we could start the treatment. So I will go ahead first and remove that tooth, do a socket shield, put the implant, give her immediate temporary, and I'm happy that I could give her tooth within 1 hour. And the next week we remove those bridges from the posteriors and do 1-1 implant for first premolars on the right and left side. And to my surprise, after 4 weeks, patient comes back and complains of pain in the region of 2 as well as upper left lateral incisor as well as upper left premolar. And I find that both these implants are not integrating well, and they failed. I had to remove those 2 implants. After 4 months, she comes back to me. Meanwhile, I came to know that she was admitted for some stomach ailment, and her calcium levels and vitamin D levels have gone down. After 4 months, she got the treatment, everything was normal. I go ahead and do the ridge split for the lower molars, do implants and GBR. And by this time, I had my intraoral scanner in the practice. So I decided to take her to the next level of what I was learning in digital dentistry. So I got her the failed 2 implants repeated with guided implantology. The socket shield had not failed, so I was fortunate that there is no loss buccally on the lateral. I put these 2 implants, guided implants, give her temporary, and after 4 months again, we go ahead do another DSD planning with 3Chef software over here, and make, again this is a CoSD programmer, do a planning 3D with natural restorations, printed models, and this is what is her next test drive with complete digital workflow. Of course, the patient is very, very delighted at this point of time. Only thing is that she wants the 2 centers little longer, and she did not want these teeth look too white because they are looking too artificial from her point of view. So we took her wish in consideration. I go ahead after a necessary time of integration into the implants. I go ahead and prep all the teeth and try and go completely digital by trying to scan with scan bodies these impressions. But this was my first time. I was not able to scan. And somehow the scan was not the implant scan body scan was not being captured on the scanner, so I had to go ahead with the conventional method and do this customized impressions for the 3 implants, get custom made zirconia abutment design, and put this custom made zirconia abutments for these 3 per implants, and then I prep all the teeth. Look at the shade difference over here between the 2 central incisors, almost east and west. One is ND1, natural dye 1, and the other is 9. But the final restoration is milled in the A2 CAD block for all the teeth, and only with the difference in the preparation thickness and 3D stain technique. Now, I tried to match the shades of all the teeth together. You will see how it looks in the end. This is upper preparation of all upper jaws. All the teeth are prepared. Of course, the bite is previously taken based on the upper lower functional taste dye, and the same bite is replicated after the preparation of teeth is done. And I go back. Now this is the clinical picture of your scans. This goes to the CAD software. From here on, using the taste dye files, we replicate individual STL file and mill it in Empress CAD multi A2 over here, and the molar is milled in ZirCAD multi because molar needs more strength, and molar had to be, it is actually a 7, but I had to make it look like a 6 because there is little space over there. And this is the final upper restorations. You can see the stump shade difference between the 2 centers, but the final is almost same. And then I go ahead with the regular routine bonding protocol for this Empress. All these upper are bonded together. You can see the left 2 or tooth number 2 is implant done second time, but hardly you can make out any difference in the soft tissues as well as in because of the natural shapes. It almost looks natural. Now once upper is done, I decide to go ahead and change the lower protemp with injected natural restoration concept. Now this is another handy concept, and I'm sure this concept will go a long way in this coming COVID times because patients' financial instability will force them to seek a little economical or alternative restorative dentistry options. Now, using the same concept of natural restoration, the wax up is done, and we delete one alternative teeth in between and print 2 models. So we have 2 models, one with alternative teeth and another with full teeth set. We create a silicon index transparent. This is a semi-transparent material from Kulzer. We create these silicon indices, make small holes on the tooth which are to be restored, and using a bulk field flowable composite and a routine composite protocol, you isolate the adjacent teeth and do etching bonding for the teeth on which you are going to inject composite through these transparent indices, and just cure after you flow this bulk flow through this transparent indices using the curing light, and within few minutes you can restore multiple teeth. Basically, the shape is taken up from these indices, and the shape is already designed and printed in the models. And once the alternate teeth set is done, you replicate the same thing for the remaining teeth. And within 1 hour or max to 1.5 hours, the function and aesthetic for the lower jaw is restored. If you use good quality materials, of course, you can give this kind of restoration for 3 years to 5 years as well. There are various materials available specifically indicated for this kind of restorations, like injected universal composite from GC, Ivaclar. Almost every company has those composites, and it definitely makes a great sense to test your taste eyes with this kind of concept. And maybe if your patient is not around for 6 months or 1 year, using this kind of composites, you can do your cases. I purposely tested this case over here, used this composite for 4 months in this patient's mouth. Everything was normal, everything was nice. Patient was quite comfortable with this, but she had already committed to go ahead with the glass ceramics for the lower teeth as well. So I go ahead after 4 months, prepare all the teeth, but before preparing, I scan the upper jaw, lower jaw, and the bite in my software, and I use that bite after the preparation to align my prepared model over there, so I don't lose any kind of information from patient's mouth. I go ahead again. I do preparations for veneers for canine to canine and occlusal, and for premolars it is occlusal and buccal. So it is a kind of overlay. So I'm minimally invasive to the patient. Prepare these restorations in glass ceramics after staining and bonding in the mouth. And the lower molars basically are done with screw retained PFM crowns. And this is how the occlusion and the aesthetic. This is the final desired shape and morphology of the tooth, and this is exactly which is replicated in the mouth. Again, no face bow, no articulators here, and this is as per her wish. She did not want white teeth. A2 cat block is converted into A3 kind of shade, and it looks nice on her face. Really, really natural. Here, because of the shape, even though it is A3 shade, it goes very, very well with her personality. And you can see a delighted patient in the end. Some fun part before she leaves, and that's how this is. Again, I don't want to talk about this so much about it. Yeah, but there's a lot of hard work which has gone behind this, and uh, let's see a small video which depicts the entire workflow, what happens in my practice as far as digital dentistry is concerned. Okay, so that was in a nutshell how the digital dentistry workflow is in my practice. The ultimate goal of technology is to make us the master of the world that we command by the push of the button. Technology is already there. Right now, there is a pause because of COVID, but I'm sure as and when we bounce back to our work in normalcy, we'll pick up from where we have left. And more patients are going to come and ask you for digital dentistry workflows because of their obvious benefits. Uh, People don't want to spend too much of time in dental offices, and if your work is entirely predetermined, designed, and using template dentistry, you can do much more wonders to your practice. And digital dentistry is no more future. The future is already here. And with this thought in mind, we want to help more and more dentists to implement this kind of workflows in the practices. With this thought in mind, we have come up with the Rich Smile Digital Dental Solutions. Since a year, we have been working with various dentists, which in India and outside India as well, providing them with the planning and designs and templates and the final restorations at times. And if any one of you wants to get in touch with us, of course, there's my mail ID and our numbers are there. You can get in touch with us. So I believe copying was never fun until now. Anyone who copies others is always looked upon and being shamed. But if you are copying nature, it is the all fun and nobody is going to complain about it. So I believe it is an era to copy nature in toto, and that's my motto. So I wish everyone good luck and wish to see you around soon somewhere. I think I'll take up questions now. Let me see if there are some questions coming up. Okay. Dr. Bhavika Sharma, why did you choose molars to be Emacs? I have learned that Emacs is preferred for anteriors. Okay. Dr. Bhavika, it is, most of the people prefer Emacs for anterior teeth and not a lucite glass ceramic, but that is something I believe if you know how to handle your occlusion well, any kind of glass ceramic is, once it is bonded, it is as good as your tooth surface, and it is as good as your enamel. And for me, lithium disilicate provides me maximum aesthetics in comparison to Emacs, because Emacs has a properties which are closer to dentine. It is more of a fluorescence. Empress is more of a translucent and more close to enamel. So if you are replacing enamel in anteriors, you should choose a material which looks like an enamel, because once it is bonded, either Emacs or Empress, they behave the same way. And if your occlusion is under control, nothing goes wrong. For molars, if it is tooth supported molar, of course I would prefer Emacs, because aesthetic is not so important in that region as much as strength is important. And of course Emacs has a more strength comparatively than the lucite glass ceramics. So my preference is always Empress for anteriors and Emacs for posteriors, if it is tooth supported, of course. Again, Bhavika is asking, why are we not able to achieve the digital outcome despite making a good design on teeth digitally? I am assuming that you are talking about your cases, because whatever I have shown over here is whatever is designed in the test drive, it is the same in the final outcome. So you need to see that your technicians are well trained on these concepts. I don't think there are many technicians in India, for that matter all over, who are really understood the natural restoration concept well. because there is a specific training required, and different workflows are there to put together to get the final designs right from the planning till your final restorations. Akanksha is asking what would be the longevity of ceramic veneers and laminates. So, as again I mentioned, if you have followed the bonding protocol and if you have followed the occlusal principles well, my mentor Dr. Rajiv Verma says that if you bond any kind of glass ceramic or Emacs to enamel, not a dent in enamel, that restoration should last till lifetime. Like if the person has these veneers in his mouth and he dies and comes back as a butterfly, then he should have these laminates in his mouth. That's what Rajiv sir says, and I believe him that because I have so far no issues with my ceramic veneers or laminates bonded well. Akanksha, again, she's asking what, according to you, would be minimum total expenditure. Okay, so that is a subjective question, and there could be variable options: the total expenditure for the patient or for the dentist. I think you need to get in touch with us. There are few numbers provided to you and email ID. You can put this question on there, and then somebody from my team will answer you on that. Tej Joshi is asking, how do you calibrate the ruler to your screen? Okay, I'll explain this again. You will measure the exact width between the two centrals in the patient's mouth using a divider, and put that divider on a physical ruler and see exactly how much is the width between the two centrals. It could be, say, 16 millimeters or 15.5 millimeters. Now you go to the picture on your PPT, and you draw those two lines, vertical lines, passing through the distalmost aspect of the both the central incisors. Put your digital ruler in that region and stretch or enlarge or make the ruler short and make it fit between those two lines and make it exactly measure 16 millimeters like in the patient's mouth. And now that ruler is calibrated. Now you don't touch that ruler. Touch that ruler in the sense you don't stretch that ruler, but you can duplicate that ruler in the software and use it to measure in specific areas wherever you want to measure. Pratik, hi Pratik. Pratik Gupta, which 3D printer do you recommend? So about 3D printers, it is again depends on what purpose you are looking for. If you are just looking to print the test die models in your practice, I'm using a Photon Anycubic printer, which is the cheapest printer on the market, and that serves me the purpose. If you are printing implant guides, if you are printing denture processes, then you need a higher version of printers like you have NextDent printer, you have Asiga printers. These are the upper range printers, but again depends on your purpose. There is no one particular printer which will serve for all purposes as of now. Pratik, yeah. Bhavika Sharma is again asking, why are we not able to? Okay, I answered that. Bhavika is asking, how did you make correction in final because provisionals were more retroclined? Yeah, so as per the test, you know that these are more retroclined. So I mean, I have to go to my CAD software and I just move the 3D file. I just move the 3D individual tooth shape in particular direction wherever I need to do the correction. So it is based in a 3D software. Difficult to explain without showing you the software version. Deprogramming was used for how much time? In this case, generally, if patient is not a TMD patient and a POIS deprogrammer is required, in such cases, I generally prefer 8 days or 12 days, depending the comfort level of the patient. And why was it required in first place? Because patient has no TMD. Yeah, so whenever you are going to raise the bite, my preference is always to put the condyles in its original position, in its so-called centric relation position, and that's where you need deprogramming. In every full mouth case, I would do it by doing a deprogramming, by allowing the patient or the muscles to achieve their normals. Priya Singh is asking how occlusion and other criteria maintained in digital planning of your full mouth case. Occlusion and other criteria maintained in digital planning. Okay, so the first part in the planning is always is a motivational test drive, where in the motivational test drive we do not take into consideration the function and biology, because patient has not signed in for the treatment, so we don't get into so much of detail. Once the patient signs up for his final outcome, then we go and design another design, where if it is a full mouth case, then of course you need to find if the patient has a TMD problems or no. If not, you need to use a different kind of deprogrammers, and give a technician or a digital technician exact file in the correct VD which you want, and from there on he will build the natural tools. And in the software itself there are virtual articulators also, or if you have taken a patient specific motion, you can do the wax up, and allowing that motion, everything which is comes in between will go away, and that will give you a monolithic wax up or a restoration. So one time bite will be enough for all the procedures? Yes and no, because it all will depend how many steps you are going to take. At times, whenever you find your trial in the mouth is perfect, you will scan that first before prepping the teeth. You will scan that bite, and that is your startup point for the case. So there would be 2 or 3 times you will be changing the bite in between during the taste drives as well, because you will be doing some equilibration of your taste drive, functional taste drives, and once the patient is comfortable with that, you will need that bite for your final restorations. So yeah, there will be a few times you will be changing the bite in between. Once you are sure that this one particular bite is completely equilibrated, and from there on you will build your final restorations. Akanksha Balay, do you believe digital dentistry as a ruling one in the next 10 to 20 years of arena of the teeth replacement? Of course, it is already there, and it's a matter of time that it will be accepted worldwide. Rajesh Dasiputra sir, hi sir. You showed the different kind of scan abutments for photogrammetry. Can you say how much accurate replication happens and how in 3D way by use of dotted abutments via usual or scanners and scan abutment? Sir, this photogrammetry is based on a photogrammetry principles, where photographs and grammetry is basically photo and light is used, and the software does the calculation. This technology is used by the road construction officers or Google to specifically map exactly in millimeter in exact mathematical measurements is done. So these dots are pre-calculated dots, and the software does some calculation. Based on those calculations, the distance is replicated in the software, and because they're attached to the implant below, we are able to detect the exact position of the implants, and it is the highest accuracy within 4 or 5 microns. You can get that accuracy. Nothing in dentistry so far can match the photogrammetric accuracy so far. And the scan flags are basically you, depending on your implant company and model, you will have different scan flags from the company. Dr. Manoj Chaudhary, longevity of indirect composite veneers. I already explained this. Ragini Parmar, sir, do you recommend same workflow for composite veneers? Yes. So coming back to this, I was shown the second case where I have done injected composite using the same protocol. And yes, that is the most next big thing happening today. For patients economics, you can use this same technology and create printed models and silicon indices, or 3D printed shells, which can help you to build composite or use flowable composites and create the same shapes and morphologies in the final outcome. We do have some cases based on that also, but I think today's seminar wouldn't have allowed me so much of time. Maybe the next time we can talk about it. So I think I'm done with most of the questions, and okay, so I think we are almost towards the end of presentation, and if any questions are left, I'll go back to Facebook again and write in person, or you can still WhatsApp or email your queries, and we will help you out with that. So I hope you had a good time with me, and some of you got certain clues. And if there is anything which we can help you with, we are always there available. So thank you once again to everyone who has been through this seminar, through this presentation. Thank you, World Dental Association, for inviting me. It's a great pleasure. I had really a good time over here. So I hope everyone is. I hope and pray for safety of everyone, and hopefully see you soon somewhere. Thank you so much. Bye. Take care.